the first. So here I will go today through 3 brief case reports, and then I will try to connect this to the information that you obtained during this whole course, yes? So that I will try to show you how beneficial for you will be the things that you learned during this course. And then at the very end I will mention one xenobiotic, and I will try to show you how it modifies the metabolism of our cell, so we can say what's the extreme situation for our cell. In detail, the metabolism of xenobiotics you will cover in one of other courses. So today I took one quite simple and well-known xenobiotic whose metabolism is not so complex. So, first, case report. So we have a male that in the last 3 months had body weight drop from 82 kilogram to 71 kilogram. Then the patient suffered from polyuria. That means that he urinated a lot, and he was also more tired than a normal person. The last 3 days before the arrival to the hospital, he was sleepy, and the last day before the actual arrival, his wife almost cannot wake him up. You as a doctor during the entrance examination found these results. So the body weight was 71 kilogram, the height was 184 centimeters. If you want, you can try to calculate the body mass index, and you can tell me how big it is. The patient was in sopor. That means that he is sleepy, and you can wake him, but it gives you a lot of effort, typically only on the painful stimuli. Then there were no evidence of meningeal irritation, isochoric pupils, dry tongue, decreased tone of the eye bulbs, and decreased skin turgor. The patient was breathing briefly. The breathing rate was around 32 per minute, and you can feel the acetone in the breath. There was no pathological findings or some severely pathological findings on heart, on lungs. That means the listening. And the arterial blood pressure was 85/50. Peripheral pulse was 140 per minute. The findings on the abdomen and legs were physiological. So, could you explain me what does it mean, meningeal irritation? That was question, or you want to answer? What is meningeal irritation? If I am no doctor, I am a wife of the patient, and you write this, so could you tell me, some of you, what is it?
Irritation in the brain.
Meningitis.
Yes, typically it's found if you have some infection of the meninges. That means that surrounds your brain, and that means that typically if you have unconscious patient, you must exclude this. Yeah? So that means that you move the head in this, and if there is no painful stimuli or any irritation of the hand, then there is no meningeal irritation. Isochoric pupils, what does it mean? I think that majority of you had this on the examination when you entered the hospital. That means that you have the same size of the pupils. Yes? That means that typically there is, for example, no bleeding inside the brain that could lead to the anisochory and also to the unconsciousness. That's only for you to translate it. Of course, you do not have to know it. Yes? Decreased skin turgor, decreased tone of eye bulbs, dry tongue. That's the symptom for what? Or there are signs of what? Of dehydration. Yes, so that corresponds the patient urinated a lot and he's dehydrated. The breathing rate is increased. Blood pressure is low. That means typically it's 120/80. So this is hypotension, and the peripheral pulse is higher than normal. The high level is 100, and if you cross 90 or cross 100, it depends on the classification, you have the tachycardia. And typically you have it coupled, low blood pressure, and high heartbeat. If we look to the laboratory examination, here are the results. The glycemia is 57. Is it normal? No, typically in fasting state it should be below 5.6. We do not know whether this is fasting or not, but still it's extremely high. In the acid-base balance parameters, you have pH 6.8, base excess minus 28 millimoles. So what's the normal pH of your arterial blood? 7.4, so this is low. And base excess correspond with this. Base excess means, if it's positive, that you have excess of bases. If you have base excess negative, that means that you have excess of acids. Yes? And low value of base excess means lot of acids inside.
Can you repeat it, please, slowly?
Yes. pH, you know what is it? That's minus decadic logarithm of concentration of hydrogen protons. And BE means base excess. That means if you have lot of bases of your body, then it's positive. When it's negative, then you do not have excess of bases, but you must have excess of acids.
If it's 0, is it neutral?
Then it's neutral. And typical value is 0 plus minus 2.5. Yes, that you will learn in other courses. But this is the typical thing what you have. Low pH, low base excess. And then the plasma concentration of ions, potassium 5.2, sodium 145 millimoles. So almost normal. And then in urine, you measure the ketone bodies. If you take the basic urine test, you have it in semi-quantitative method, and we say normal, 1 cross, 2 cross, or 3 crosses. That means 3 crosses means high elevation of ketone bodies. Yes, that you have the test strips, you can buy it in the pharmacy and put it into your urine, and you will see on crosses blood, hemoglobin, ketone bodies, glucose, proteins.
What is the normal weight?
No ketone bodies.
No pluses at all?
No plus. No blood, no proteins, no glucose. And the ketone bodies, that depends, but typically you should not have it 3 crosses. In starvation, you can have maybe 1 cross as the maximum. But 3 cross means a lot of ketone bodies in the urine. So what would be your working diagnosis for this? And please do not press the other thing.
Ketoacidosis.
Yes, ketoacidosis.
Diabetes and hyperglycemia.
Yes. So it's patient with hyperglycemic, ketoacidosis, in coma due to the type 1 diabetes. And right now I will try to show to you how we can define these changes that you saw in this patient. And first we will start with the state of the patient during starvation. We will try to connect the knowledge that you have what happens in the starvation. And from this I will try to go to the type 1 diabetes to be able to see why do we have these lab results in these patients. So if we start with the starvation, we start with the fact that we do not have a true starvation, but we start with the starvation after overnight fast. That means that the physiological thing that all of you have, since typical people do not eat when they sleep. Yes? That means that if you are after overnight fast, without a breakfast, your blood glucose is still quite normal. Yes, it's around 4.5 millimoles. And what starts to modify our metabolism is the increase of insulin-glucagon ratio. That means that the insulin concentration lowers and the glucagon concentration rises. And therefore, the whole ratio will be lower. It means that after this hormonal change, you will activate some pathways that will be the result of them. One example is, for example, the glycogenolysis in human liver. You know that for around first 12, 16 hours, glycogenolysis in liver, that's the main source of blood glucose. Since your body doesn't know whether you will eat a breakfast or whether it will be some longer starvation, of course, in this time, you also, to some lower extent, activate the gluconeogenesis. And the hormone that stands behind this is the cortisol plus the decrease of the insulin-glucagon ratio. What is the result is that your liver starts to release the blood to your bloodstream. That means they activate their glucostatic function in favor of increasing the blood glucose level. And that means that they do not consume the glucose. What are the sources of the glucose molecules? So you have the lactate, since you have there the cycles, plus you have there the lipolysis in peripheral tissues. Hormone-sensitive lipase is also activated by decrease of insulin to glucagon ratio, and the released fatty acids can be consumed in the tissues, and they can also give energy to the gluconeogenesis process in the liver. Plus, you have very mild activation of the proteolysis in skeletal muscle, but it's nothing very big since the gluconeogenesis is not at the maximal level. Yes, still here the main source is the liver glycogen. So some proteolysis is inside. Alanine is used for the gluconeogenesis, but not to very big limit. Here you have, for the repetition, the picture when do we use what sources of glucose. So after overnight fast, we are after the diet for quite a long time. That means that we are right now in this period when glycogen is the main source. And when we switch to the long-term starvation, that's the point when the gluconeogenesis is rising in the importance. And you know that typically the crossing point is around 16 hours. It depends how many molecules of glycogen, how many glucose molecules you can release from the liver glycogen. So it can be sooner, it can be, for example, 12 hours after the last meal. If we then go to something that we call simple starvation, that means you are a healthy person and only you do not have meal. So there we can define 3 basic phases. So if we continue from the overnight fast, and the whole day you do not have a meal, you are in the early phase of simple starvation that durates around 2 to 3 days. And in this phase, your body prepares for the starvation. It produces new enzymes, and it shifts the body metabolism to the starvation state. Here, the main hormones for this early phase is the increase of glucagon, cortisol, and catecholamines, and concomitantly you have the decrease of insulin. That means that the insulin-glucagon ratio is even lower than was in the first situation. If we are speaking about days, then of course the main source of glucose molecules is the gluconeogenesis in human liver, and the main substrate for the new carbon atoms, that's the proteins from the skeletal muscle. That means the amino acids that are released from skeletal muscle proteins. The proteolysis in skeletal muscle is activated by the cortisol plus the decrease of insulin-glucagon ratio. And as you know, the skeletal muscle cells can metabolize some amino acids, and they typically release quite high quantities of 2 amino acids. That means that they modify the spectrum of the amino acids, and they favorize the release of alanine plus the release of glutamine. The alanine can go inside the liver to feed the gluconeogenesis, and as you know, glutamine can also go to your enterocytes to feed them, since enterocytes and other rapidly dividing cells typically utilize glutamine as the energy substrate. So that's the answer on the question, what will feed the enterocytes when there is no food? That means no energy for enterocytes from the diet. And that's of course their main source if you have a meal. Yes?
Glutamine goes only to the enterocytes? It can go to the liver?
Yes, it goes also, but this is the special characteristics to answer how do you will feed the cells that typically have the...
What is the complete answer about the glutamine? That's
What do you mean complete answer?
Where does it generally get?
Of course, it generally can go everywhere, but the main organs that will use it, that's liver, that's enterocytes, and that's the immune system. In each of them, you will see some different metabolic pathways that you will review in the second year. The whole term is glutaminolysis. And as you see that in lymphocytes, you gain more aspartate, but you do not have to Y. In enterocytes, you more gain alanine, and these go subsequently to the liver. So the glutamine can go directly to the liver or after the modification inside the enterocytes or lymphocytes.
And how does this modification occur?
What?
How does this modification occur? Like how does the glutamine give alanine?
They take some part of energy from it, and then they release the rest of the molecule, typically in form of alanine. So some small amount of energy they take, and the rest they send in alanine.
The liver?
Yes, to the liver. That goes directly to the liver. This alanine plus the alanine directly from skeletal muscle. But this whole process you do not have to know in detail. Yes, only to show to you that liver are not the only consumers of the amino acids, also the enterocytes. What happens to in other organs? Of course, in adipose tissue, you have increase of the lipogenesis, and the released fatty acids and glycerol are utilized typically in the liver. Glycerol as the source of carbon skeleton for glucose, plus fatty acids are metabolized at the level of liver. First portion is used for the energy. That means to feed the gluconeogenesis pathway. Second, since the fatty acid supply in liver is very high, the increase of acetyl-CoA molecules will be utilized in ketone bodies production. Some tissues can use the fatty acids directly. Yes, some tissues take both free fatty acids and ketone bodies, and typically, for example, skeletal and heart muscle consumes the fatty acids directly. Why it's important to have the ketone bodies is not only due to the fact that they give the energy to peripheral tissues, but second reason is that also they limit the proteolysis in the skeletal muscle. And that's quite simple reason. If you degrade skeletal muscle proteins, you will lose the function. If you will degrade lipids from adipose tissue, that's their role. That means to give you energy. That means if your body has enough ketone bodies, then they inhibit to some extent the proteolysis and therefore protect our body from severe protein catabolism. So this is the way how intermediate, for example, ketone bodies can regulate some metabolic pathways. Yes?
I have a question. So here we said that most of the acetyl-CoA is going to go to ketogenesis. That's because you won't have the oxaloacetate for the Krebs cycle because of the gluconeogenesis?
That's one reason. And second reason is that in the beta oxidation itself, you produce NADH plus FADH2. That means that some amount of energy from fatty acids you release even without the usage of acetyl-CoA. So first thing is that oxaloacetate is taken to the gluconeogenesis, therefore limiting the capacity of Krebs cycle. Another thing is that the intensive beta oxidation in liver mitochondria, only the beta oxidation give quite high quantities of energy. Since per each rotation, you derive one NADH plus one FADH2. And this gives you directly around 4 ATP molecules. Then, of course, some molecules of acetyl-CoA are degraded also in the Krebs cycle, but you do not have to have so big here the consumption, and therefore you can save them for the ketone bodies production. So liver cells first must have energy, but since the beta oxidation itself gives them energy, therefore not all molecules of acetyl-CoA must be degraded in Krebs cycle. And the oxaloacetate is taken out, and therefore it's limiting the pace of the Krebs cycle also. Any other question?
Yes. You said that the lipolysis is in the liver, but isn't it in other tissues?
Lipolysis is in adipose tissue. You said in liver?
Yeah, you said in the liver and the beginning.
Oh, sorry, the lipolysis in adipose tissue. That was my mistake. In adipose tissue, of course. You have the lipolysis also, for example, in skeletal muscle that you have there inside, but the typical storage fat you have in adipose tissue. But if you are highly obese, then you have, of course, the fat in other depositions also. In this state, in those 2-3 days, we switched our metabolism to the state that we call the adaptation phase. We call this phase the protein sparing phase. That means the main source of energy, that's fatty acids and ketone bodies, and what can be converted to glucose is converted to glucose, but only to the extent that can be utilized to your body. That means that your body tries to save the proteins for a very long time, and therefore only the minimal quantity of proteins are transformed to the gluconeogenesis. And since our body is quite well prepared for the periods of starvation during the evolution, then we are quite effective in this. And the typical male with no illness, no trauma, no infection, can survive quite long time in this adaptation phase. How long precisely, that depends on many factors. That means on the amount of storage fat, the amount of storage of especially proteins in skeletal muscle, whether there will be any infection, any trauma. But as the middle, we can say around 7 to 8 weeks in this adaptation phase. As you know, typically in the past, there were no total starvation. The typical starvation looks like that you have only limited intake. And therefore, of course, you have prolongation of this adaptation phase, and it depends on the fact how big calorie restriction you had. In the terminal phase, you have 2 options. First, you exhaust your proteins, or you exhaust your lipids. But in that state, you are not able to feed your tissues with energy that they need. You will typically develop the immunosuppression, and you will be killed by some infection. Any question to this, to the simple starvation?
When you were talking about adaptation phase, you said typical male?
Female, male, or human being. Okay. But of course, there are different amount of, for example, storage fat.
So is it more, so I think that women have
more storage fat.
Is it more beneficial to?
You cannot say this. That's absolutely different. It depends what type of starvation it will be. Yes, typically you combine it with some infection, so I cannot say who's more resistant to it. It's a highly individual thing. To have more fat is sometimes good, but sometimes it's not good, since what you typically can run out, that's the proteins. And then typically males start with higher amount. But this is really individual.
This is a bit of a weird question, but when you die of starvation, which organ is it that lacks? What's the primary organ which is defective in a certain substrate?
I think that typically you die due to some infection that will kill you.
Is it weakens your immune system?
Yes, typically you die from something as pneumonia. Or some other infection, and that it's difficult to say what organ, since it's the generalized infection it will be. How we can use this for type 1 diabetes? Type 1 diabetes is quite extreme type of starvation, and you can say that it's the starvation when you have enough nutrients. The problem here is that your body can starve due to 2 reasons. The typical reason is that you are missing the nutrients. Other reason is that you will miss the anabolic signals. And that's the type of starvation here. Since in type 1 diabetes, when it's full type 1 diabetes, you have the total insulin deficiency since you have no pancreatic beta cells. Yes, there is autoimmune process that destroys the cells producing insulin. And what happens in that state is that maybe your body has the nutrients, but since you miss the anabolic hormone, simply we can say that the body has no information about it. And what are the results of this state? First is that you develop extreme hyperglycemia. The extreme hypoglycemia is developed due to basically 2 reasons. First is that typically the insulin limits the rate of gluconeogenesis. Even if you have long-term starvation, still you have some secretion of insulin, and this will limit the pace of gluconeogenesis. If you have no insulin, then you have extremely fast gluconeogenesis that it's not suppressed by anything. That means your body is trying to produce as many molecules of glucose as it can. Second thing is that the glucose cannot be utilized in some tissues, since you know that glucose in some tissues can enter the cell only in the presence of GLUT4 transporters that are insulin sensitive. That means they are in the cell membranes when there is insulin. And this is, for example, in skeletal muscle, adipose tissue, and heart. And if you take the combination, high production of glucose, and no possibility for peripheral cells to take the glucose, only for some of these peripheral tissues, you will develop the hyperglycemia. That means accumulation of glucose that's produced in liver in the circulation. If you accumulate the glucose, it will also explain you why these patients typically have polyuria. Since your kidneys have only limited ability to return the glucose molecules from urine to the blood. We call this a renal threshold, and it's around 10 millimoles of blood glucose level. If you cross this threshold, then glucose will be in your urine, that we call glucoseuria. It will take water, therefore you have polyuria. You will be dehydrated, and you start to drink a lot. And that's the typical thing what you see in the patients. They drink a lot, and together they urinate a lot. Then if we look at lipid and protein metabolism, there must be something what will feed the fast gluconeogenesis. And as you know, the energy is typically supplied by fatty acids. Hormone-sensitive lipase is inhibited by insulin. If there is no insulin, you have very fast uncontrolled lipolysis. Typically, insulin also blocks the carnitine shuttle indirectly. Therefore, you will have very fast beta oxidation if you have no insulin. And this will give you the energy for the gluconeogenesis. Plus, concomitantly, you will have a lot of acetyl-CoA molecules in the liver mitochondria, and therefore you will produce extreme quantities of ketone bodies. And as the result, you will have decrease of body pH, and it's due to the ketone bodies, and therefore we call it ketoacidosis. That you saw, accumulation of acids means very low basic excess and low pH. We saw it in our patient. Typically, these patients also have the hyperlipoproteinemia. They have elevation of VLDL and chylomicrons, and that's due to the reason that insulin activates the lipoprotein lipase in adipose tissue. That's the lipase that should be active in anabolic state. If there is no insulin in the blood, these particles will stay longer in the circulation. And from the proteins point of view, you have here very extreme and fast protein catabolism, since insulin is typically protecting your skeletal muscle proteins from degradation.
Can you please repeat the hyperlipoproteinemia?
You know lipoprotein lipase. There's the enzyme degraded in chylomicrons and VLDL. And in some tissues, lipoprotein lipase is activated by insulin, typically in adipose tissue. If you do not have insulin, this enzyme is inactive. Therefore, these particles will stay in the blood circulation.
How come the ketone bodies, the acetoacetate doesn't inhibit the AHSL?
Yes. To some extent, they will inhibit. That's true. But the problem is that if you really have no insulin, then you are missing the strong anabolic hormone. So we have some other regulations, but they simply are not strong enough to inhibit the effect of glucagon, cortisol, and other. Even if you have very long-term starvation, you still have the basal secretion of insulin. And this is the result what happened if you have no insulin. That means total catabolism in your body, and you produce extreme quantities of glucose and extreme quantities of ketone bodies. So you produce the same things as in starvation. The problem is that since it's not blocked by the insulin, at least to some extent, you make more than you can utilize. And therefore, as you see here, you have a lot of nutrients, but you cannot utilize them in the good way. And therefore, we can say that this is also some kind of starvation. Your self starve. Your cells tries to produce more energy substrates, but you cannot utilize them in an effective way in some tissues. So any question to this?
In which week this occurs, like of starvation?
This is not starvation, this is type 1 diabetes. And it depends how big the dysfunction of pancreatic beta cells you have. You know, typically you have the start of the pathological autoimmune process, then is something that we call a honeymoon period. And after that, you have the occurrence of the diabetes. So that's the time when the patient gets the diagnosis by the doctor. And it can be different time, yes, but you can say it can be 8 months, 1 week, 8 months, 1 year, something like it, till the full development. But sometimes it's really quick, sometimes it's prolonged. That depends on the severity of the autoimmune process. So, was it understandable for you, the starvation and type 1? If so, then second, here we can say absolutely opposite story. We have 42-year-old patient that had the symptoms of angina pectoris. What is it?
Strep throat. Strep throat.
Just angina in your heart.
Yes, it's something, as we can say, smaller myocardial infarction. You have the stable angina pectoris, unstable angina pectoris, and myocardial infarction. And you have different variety of the symptoms. Only what we can say here, this is unstable angina pectoris is almost the infarct, myocardial infarct. You only wait for the big rupture of the plaque. And therefore, you typically here do something with these patients very quickly. So the patient was diagnosed with the coronary atherosclerosis. Then you did the intervention in the coronary arteries, and then you start to examine that patient. The body weight was 110 kilograms, and body weight was 183 kilograms. So right now, calculate the body mass index, and I will ask you in a few minutes how high it was. Do you know what's body mass index, BMI?
No.
All of you? Means the body weight, and here you have body weight multiplied by 2, or to 2, square 2. 32.8. So that's abdominal obesity, yes? Here you see the circumferences, so that's of course bigger than they should be. And arterial blood pressure here was 160 over 105. So that's much higher. The border is 140 over 90, yes? And right now, maybe even lower. Here, it was diagnosed that there is the stenosis of the artery, Acuminous artery. That means the artery supplying your brain. So we can close it that the patient had the maybe whole body atherosclerosis. If we look at the laboratory parameters, glycemia was 6.2, and it was the fasting value. So is it normal, or higher or lower? Is higher, for it should be around 5.6, the maximal value. Concentration of triglycerides, 5.5, normal, high, low. Physiological is around 1.7, the maximal value. Total cholesterol, 5.9, and HDL cholesterol, 0.86. So normal, or too big, or too small.
Total cholesterol is too big, and HDL is too low.
Yes, this is too big, and this is too low. Yes, since you know that HDL we want to have higher than 1 for males, and higher than 1.2 for females. Then, here you have the oral glucose tolerance test. You will learn about it in the summer semester. That's the kind of the test when you give a standard dose of glucose, and you see how the body is able to cope with this glucose. And I can tell to you that these values are higher than they should be in normal patients. So what do you think is the diagnosis here? That's first, that's abdominal obesity, that's true.
Accumulation of visceral fat and hyperlipoproteinemia.
Yes, high lipids. So dyslipidemia we have here. The patient has high glycemia. We call it impaired fasting glucose or impaired glucose tolerance. And there was high blood pressure. So this patient doesn't have the diabetes itself, but it's quite close to it. The impaired glucose tolerance we call pre-diabetes. So the patient is coming to the diabetes, and this will be patient with type 2 diabetes in future without any changes in his lifestyle. So
what is type 2 diabetes?
we will come to it. Yes. Type 2 diabetes, to show you the changes, we will start with the changes, what happens in your body after a meal. So before we speak about the fasting state, and now we will try to describe what happens to you in a well-fed state, that means after a meal. So we will use this picture for it. And on this picture, you have two big differences from the previous. First is that here you have the nutrients, that means glucose, amino acids, and fat in the GI tract, plus here you have insulin. So if you take a meal, you have nutrients, plus you have the anabolic hormone, that means insulin. If we start with glucose, what can happen with glucose in your body after a meal? First thing is that it can be incorporated to deliver glycogen. As you know, nutrients as glucose and amino acids go directly through vena porta from enterocytes to the liver cells, and the liver cells can store the glycogen. Second possibility, what you can do is to do the glycolysis, that means convert the glucose to pyruvate, and then you can convert the glucose to storage fat. If you have high intake of saccharides and you fill the glycogen stores, second storage compound will be triacylglycerols. And then some amount of glucose molecules can go through the liver without any change, and they will be consumed in your brain and in other peripheral tissues. So here we have, for example, in adipose tissue, where you will convert the glucose to storage fat. They can go into your skeletal muscle cells, where they will recover the deposits of glycogen, or they can burn them, and then it can go to the red blood cells, and they will produce lactate in the whole Cori cycle. So you can utilize them in the liver or send the glucose to the other tissues. For amino acids, the story is quite similar. They will go through vena porta to the liver cells, and here you can do also some things with it. First, you will synthesize the proteins that were degraded during the period of starvation. There was some degradation of proteins, so you will recover them. If you have excess of amino acids, then of course you can convert them to storage fat, since you know that you have no storage protein. Therefore, excess of amino acids will be utilized in liver for the formation of triacylglycerols molecules, and amino nitrogen will be converted to the urea molecule. And the third thing, similar for glucose, the amino acids can go to the rest of the body, and there can be utilized for the synthesis of proteins in all your tissues. So that means that you can utilize this amino pool in the whole body. For the lipids in the diet, you know that the story is slightly more complicated, since they do not enter the portal vein, but after the absorption in enterocytes, the enterocytes will produce the lipoprotein particle that's called chylomicron particle, and this chylomicron particle will go through the lymphatic system to the whole body, since the lymph system ends at the point of thoracic duct, where it joins the blood circulation, and this will send them to the whole body. In the body, the chylomicron particles can be metabolized by lipoprotein lipase, and in the peripheral tissues, you release fatty acids, and these can be oxidized in the peripheral tissues, or they can be stored as the storage fat, typically in the adipose tissue. You can say that all these directions, the insulin is activating. Therefore, it's in the blood. The yes?
Usually the amino acids will become pyruvate also when I'm fat.
Yes.
Like if I ate something and I don't need the pyruvate from the amino acids, why would it happen?
Yes, this is the simplification of the pyruvate. That means that you will convert them to carbon skeleton and to amino nitrogen.
Okay.
But here you have the pyruvate. Since it's the scheme, that means that simplified, it should be the carbon skeleton.
Okay.
What you can say. Other question? The chylomicrons, when I metabolize by lipoprotein lipase, will return to the liver, whereas the chylomicron remnants are cached and degraded. And was the last part of the lipid metabolism after a meal is that cells in liver, that mean hepatocytes, will produce a second lipoprotein particle that is very low density lipoprotein. They put inside the fat produced de novo, that means from amino acids and glucose, or the fat taken from the chylomicron remnants, and the VLDL will follow the fate of chylomicrons. That means they will go to the tissues where is lipoprotein lipase, and it will be metabolized inside to release the free fatty acids that can be burned or that can be in adipose tissue stored. So any question to this? That's what happens in your body after a meal. What happens to your body if you are obese is very similar. The thing, if you are obese, means that you are for long-term time in imbalance of your energy metabolism from the point of view that energy intake is higher than energy expenditure. That means that you can say that your body stays in the well-fed state for quite a long time. And that means that you will synthesize more storage fat, and therefore you add your body weight and you increase it. And that's the obesity. You gain the body fat and you became obese. And typically, since the people do not have so high physical activity, they do not burn the storage fat during the episodes of physical activity or during the episodes of starvation. What happens here is that if your body stays in the well-fed state, then they are typically for a long time higher values of insulin than they should be. Or you can say that there are no episodes of the drop of the insulin. And as you know from real life, if you have some stimuli that are for a long time and they are still the same, you became less sensitive to them. That means you became more resistant to them. And this is the thing what happens to your insulin, that the patients in obesity, since they were for too long in a well-fed state, they develop the insulin resistance. That means they still have the normal blood glucose level, but the cost is that they must have higher insulin. That means they have hyperinsulinemia and still the normal blood glucose level. In this state, you can spend some time and your cells, pancreatic beta cells, are trying to keep you in this state, but they must pay by increased insulin secretion. At one time, the cells are not able to produce more insulin. And that's the time when you, from normal obesity, switch to impaired glucose tolerance. That means that your insulin is not able to keep the blood glucose level at the normal state, and that's the state where is our patient. That means the patient is obese, has insulin resistance, and his pancreatic beta cells are not able to produce enough insulin to keep the blood glucose level normal. And from this time, you have to wait some other years when you develop the type 2 diabetes. In the type 2 diabetes, the pancreatic beta cells are even weaker to keep the glucose level in the physiological ranges, and we only, due to some classifications, say that if you have fasting blood glucose level higher than 11.1, you have type 2 diabetes. Before the 11.1, you have the prediabetes, impaired glucose tolerance. So what you will see in laboratory of these patients, they have the hyperglycemia. That's true, since their cells are resistant to insulin, and therefore they will not take enough molecules of glucose. Plus, what's other thing is that they have typically high lipoproteins. That's other factor, since their body is for too long in the well-fed state, they produce more VLDL and to some extent also the chylomicrons. But the chylomicrons are typically not so elevated. What is more elevated here are the VLDL particles, due to the fact that they have increased de novo production of lipids inside the liver. What's different from type 1 diabetes is the fact that these people typically do not have ketone bodies elevation. And the reason for this is that there are still some insulin levels, and these insulin levels are able to inhibit the hormone-sensitive lipase in adipose fat. They are able to prevent excessive beta oxidation, and therefore two key regulatory steps in ketone bodies production are still inhibited by insulin. And typically, if there is some insulin secretion in these patients, and there is even higher than in normal people, you do not see in them the ketone bodies. But we still call it diabetes mellitus, since the people have hyperglycemia and the hyperlipoproteinemia. So it's diabetes, only type 2. Type 1 is typical with ketoacidosis. Type 2 is typically without ketoacidosis. So, any questions?
Can it be reversed? Like,
Yes.
This is put by like bad diet, right? Like you get it because of like
Yes. Or no physical activity.
Yeah, and can you put it back? Like, by doing
It can. The sooner you lose your weight, the better for you. And the people at the obesitology department here said, and it's, I think, much more general rule, they took it from somewhere else of the world, that it's better to be fat and fit than unfit and unfit. That means if you have mild obesity, but you do the physical activity, you typically have better metabolic parameters than people who maybe are not obese or only very slightly obese and do nothing. And the reason for this is that if you are slightly obese and do the physical activity, then you burn the fat. That means that you burn the fat from your skeletal muscle, and that's one of the key places where the insulin resistance occurs. So the first thing, if you have the obese person, what you will try to force him to do is to start moving. The second thing is to lose the weight. But first thing is to start moving, and typically this is accompanied by the weight loss. But to limit the food intake in these patients, typically will keep 1, 2, 3, half a year maybe, but that's enough. And they will return. So the key factor is burn the lipid from skeletal muscle, do the physical activity.
So you said that the faster the patient loses the weight, the better it is.
Not faster, but the sooner.
The sooner. But is there any correlation between the chances of full recovery, or is it just, does it manifest?
That's absolutely individual. You have people that have obesity and they never had type 2 diabetes.
No, but since you said sooner that they lose the weight, why does it have to be?
The sooner, when you see that the patient is increasing the weight, the sooner he will start returning to the normal, the better.
Yeah.
If you wait when you are 300 kilograms,
I thought you meant after
then you will have the diabetes.
Yeah.
Yes, but for example, my father is obese quite a lot and still without diabetes, and he's 80. So that are good genes. Yes, and if you look at the hospital, very often younger people have the obesity, and in him, good genes.
Isn't it dangerous to lose weight dramatically fast? Could increase the chances of...
It's not recommended to lose it absolutely rapidly. But you have some patients that typically must go to some severe surgery when you put to them quite drastic, what we can say, diets.
So if someone has surgical intervention in order to...
Yes, that are typically when the symptoms are so severe, that means the complications, cardiovascular complications, they're typically, sometimes it's almost impossible to do operation in morbid obese patients. Since the morbid obese patients have very bad wound healing, they have immunosuppression and these, and therefore you recommend them to do the quite quick weight loss, and then they can undergo the surgery. But this is not the whole. The majority of people can lose the weight slowly, and you can say that the first thing is really increase the physical activity, then to lose the weight. And if you do it 2, 3, 4 kilograms per year, that's good. If you will continue with this for 10 years, then you are minus 20, minus 40, and that's typically enough. So really, typically the doctors do not recommend in 1 year minus 40 kilograms. That's not good.
When you're trying to undergo the weight loss and you're doing exercise, does it matter what type of exercise you're doing, or is it just important that you get you ensure a caloric deficit?
Typically, you recommend some normal physical activity. That means aerobic examination, since the people will more tend to stay with it. You know, this is the real life, yes? If you order to somebody who has 150 kilograms to run sprints, then the probability that he will stay with it for 2 months, it's not very high. So the basic thing what you can recommend is, for example, 1 hour walking with the bag on the back. That's the beginning. And then you can intensify it if you see that the compliance is good.
Can't they simply wash their weight from the beginning to get their weight down, so that when they do the exercise, let's say 1 month after they start their diet, the exercise comes to them more easily?
That's other thing. That's other thing that typically, really the first thing, they should start moving by any mean that you can, and that you can speak good, so you see that it's not a problem for you, so what we will do at next. And the simplest way how to treat obesity is really to start moving, not to restrict the food. That very often will durate limited amount of time.
And can the type 1 be treated as well?
The thing is that here I showed to you, first it was didactic to show to you what you know from the course, to bind it to some case report. What you will learn is that right now we have, of course, the people who have the overlap. Yes, so you can have the destruction of pancreatic beta cells, and you have it in type 2 diabetes also. Yes, they are so exhausted that there is some process behind it that they will destroy it. Yes, but is the schematic thing for this year, and you still have 5 years to study, is the type 1 is the absence of insulin. Type 2 is you have the insulin, only the tissues are resistant to it. In type 1 diabetes, the cells are nicely sensitive to insulin since they are lacking it. So you can say that they are typically craving for the insulin. So if as a doctor will give the insulin to the patient to start treating the type 1 diabetes, the response of the patient is typically very good. For the cells want to take the insulin. In type 2 people, they do not respond to the insulin at the adequate manner. They are resistant to it. But you have some overlap between these two diseases.
Doesn't that mean though, if in type 2 you don't respond to the insulin, doesn't that mean that you're supposed to lose weight?
You typically start with this state that you will do the dietary interventions and the physical activity interventions.
No. That your body itself is supposed to just start beta oxidation and lipolysis.
Now I do not understand what you mean.
If Yeah, but you said that the body doesn't respond to insulin, right? So
It's more resistant to it. It responds, but to limited extent.
doesn't that mean it should respond more to the counter-regulatory hormones and activate?
To some extent, you can say that it's much more sensitive to the counter-regulatory hormones.
So how come they don't start beta oxidation?
They do not start, for still the insulin is blocking it to some extent. And what's crucial for you is that not all pathways have the same sensitivity to insulin. As you see here, that for example, this pathway is much more sensitive to insulin than the previous one. Yes, we said to you that insulin activates, inhibits, but sometimes the sensitivity is higher in some pathways than in the other.
Is it possible to have type 1 and type 2 diabetes at the same time?
You can.
How do you fix that?
How to fix it, that depends what's your bigger problem. The first thing is, then we do not have type 1 and type 2, but you can have the autoimmune process here. Then you must treat it, what is limiting you. So the first you want to control the blood glucose. If you do it, then you can think about, for example, islet transplantation and other things. Last question. I think that before this we will take the break, so till 34. She was healthy, and then she became to vomit and had diarrhea and had suprapubilia. When her mother took her to the GP, she was diagnosed with some gastroenteritis, and she was recommended to have a tea diet. According to this recommendation, the mother gave to the small girl small amounts of tea in hour intervals, and then when she tried to wake up at the midnight, she was not successful. Since the baby do not react on this. Therefore, she was taken to the intensive care unit, and she was diagnosed with a deep coma, and you measured these values. So glycemia was 1.5, pH was 7.17, base excess was low, -16, and there was hyperammonemia, around 110 micromoles. In the urine, you found no ketone bodies, and if you then do some further laboratory examinations, you found that in the blood are increased free fatty acids, but there is decreased concentration of beta-hydroxybutyrate. So, glucose, normal, high, low? Low. pH is low, acidic, base excess is low. That means accumulation of acids, but as you see, no ketone bodies. So one reason for increasing of decreasing pH is excluded, not ketone bodies. Then if you looked into the analysis of acyl carnitines, you found the increased accumulation of octanoyl carnitine, that means C8 fatty acid that binds to the carnitine. You ordered the therapy that consisted of the administration of glucose, and after this, the neurological state and the consciousness recovered. So the baby returned from this metabolic crisis. And to prevent other metabolic crises in future, you prescribe or recommended to the mother to prevent long starvation of the girl that's more than 8 hours, the starvation. So, what do you think could be this?
Deficiency in some enzymes concerning the transfer of fatty acids within the pancreas.
That's one possibility. So in general, we can say that it can be some defect of beta oxidation. You have high, the simple thing, high fatty acids and no ketone bodies, and the girl is starving.
High ratio of insulin to glucagon.
Then you do not have the high fatty acids. If you have a lot of insulin, it will inhibit the lipolysis. Yes. So what is different here is that you have fatty acids, and even during starvation, they are not converted to the ketone bodies.
So if we have less, we don't have ketone bodies, that means we have less production of acetyl-CoA.
Yes, you do not have the production of acetyl-CoA. And the question is right now, at what stage is the problem? Yes.
Could be at the stage of beta-ketoglutarate because it can't produce acetyl CoA.
Yes, the thing is that it can be everywhere. From these values, you are not able absolutely to say where is the defect. There is one thing, when we will go through that story, that will help you, and that's this. Since you know that you accumulate C8, that means that some beta oxidation occurs. There is the beta oxidation, therefore it won't be the defect in the transport, but it will be the defect of one enzyme in beta oxidation, and when you accumulate C8, then it means that it must be defect of medium chain fatty acid dehydrogenase. Since you accumulate the fatty acid, that should be metabolized by it. But we will go through it and explain why it's this defect. If you close it as the beta oxidation disorder, you are correct.
So I just have a question, because it's bound to the octanol carnitine, right? I thought in my head now just the carnitine is between the shuttle into the mitochondria as well. But you're saying now this is the plasma of octanol carnitine. So it's the synthesis of the fault that you said. The next slide.
No, it's not fault. The thing is that if in your cell something accumulates, it will try to find alternative ways how to get rid of this. And if you accumulate derivative of fatty acid, or here octanoate, then it can use it can use CoA, coenzyme A, but it's too big. So it will use smaller thing, and that's carnitine. And as I will explain to you, that's the typical thing what you see. The thing that's accumulating will be bound to carnitine, and that you will measure in the blood. Typically, you do not measure it since your beta oxidation is working. But in this state, you will make opposite direction of the shuttle, and the carnitine will be in form of acyl carnitine in the blood. So this is the alteration of the metabolism. So why this disorder for this patient? So as you know, beta oxidation and altogether fatty acids serve as the main source of energy in you if you have the starvation. You oxidize them, plus you typically should produce ketone bodies from them. As you saw, that was deficient in this girl since there were no ketone bodies inside. If you make a defect everywhere in the beta oxidation, it will lead to similar result. You can have both the defects of the transfer, that means the carnitine shuttle itself, or you can have defects of the enzymes of beta oxidation. That means the process inside the matrix of mitochondria. And you can distinguish these two defects first by the molecular genetics, when you will look at the genes that are defected, or by the different laboratory results of these patients. But what will be common for all these defects is that you have patients that have low blood glucose level, since she's missing, or the patient is missing, the energy for the gluconeogenesis pathway, and the patient has low ketone bodies, or they can be maybe normal or low. And that means that the patient is lacking the acetyl-CoA to produce the ketone bodies. So we speak about hypoketotic hypoglycemia during the starvation. And if you are healthy, then you should have ketone bodies and maybe some mild hypoglycemia, but not 1.5. That's too low. Second thing, what will happen is that if you have this state for chronic time, then for some of these effects, you will accumulate the toxic metabolites, the alternative metabolites, and this will lead to problems in the cells that intensively run on beta oxidation. That means your liver cells, we call it hepatopathy, and then your muscle cells. So we call it myopathy, or when it's hard, then it's cardiomyopathy. So if we return to the normal metabolism, the pace should be that you start with lipolysis in adipose tissue, then you transport the long-chain fatty acids into the mitochondria, and then you do the spiral beta oxidation. And you know that in the beta oxidation itself, you do 4 steps. First is the dehydrogenation by the acyl-CoA dehydrogenase. Then you do hydration, that means you add water. Then you do the second oxidation, and then you do the phtholysis. What makes it slightly more complicated is that you have different acyl-CoA dehydrogenases for different length of the chain of the fatty acid. So we have short chain fatty acid dehydrogenase, medium chain fatty acid dehydrogenase, long chain, and very long chain. And all these steps can be defective, plus the transport itself can be defective. And if you take all these defects that we call beta oxidation disorders, we have one of the most common group of metabolic disorders, the inborn errors of metabolism. And therefore you will heard about them so frequently. And if you meet the patient that has hypoglycemia plus low ketone bodies, you must think at one of the very first position about this kind of disorders. If you have the defect, what will happen in your metabolism? So you will have the fatty acids in your blood. That's normal. Lipolysis is not effective. But then what will happen is that you at some level block the beta oxidation. And your cells will try to use alternative metabolic pathways how to get rid of this accumulated substrate. And as you know, during the lecture, we only slightly mentioned the omega oxidation. This is the pathway where you start the oxidation of the fatty acid from the last carbon. If you do this, then the result of the metabolism will be dicarboxylic fatty acid. Typically, you do not see them in your metabolism in quite big amount. But if you have the problem in some dehydrogenase, in some metabolic step inside the mitochondria, then this alternative pathway will be very efficient or much more efficient. So if you see something that's dicarboxylic acid, aciduria, and typically C8 and C10, you know that maybe there will be some disorder inside the beta oxidation. Second, that's the question on the acyl carnitines. The acyl carnitines are produced due to the fact that that's the way how the cells can get rid of the accumulated substrate. That means that that's the way how to make the acids more polar, and you will detect these acyl carnitines in the blood. And it depends on the place of the defect whether you will measure date CH or C12 or C16. That depends where precisely the defect will be located. When this disease typically starts is about 7 to 12 months. And first is that it can be during that time due to the fact that the babies typically start to sleep for longer time. Second thing is whether when you have some more severe infection that will lead to anorexia, or as you had there, the vomiting, that means some long-term starvation. And this will release the metabolic crisis since the body is not able to shift from the well-fed state to the starvation. That means that the body is not able to produce enough glucose and enough ketone bodies to supply the body with an alternative energy source. And after a few hours of the starvation, the babies will run out of their liver glycogen. And since they are not able to start the gluconeogenesis efficiently, they will go into the unconscious state and to the coma since they do not have enough energy for their brain. Therefore, we also use as the treatment here quite simple thing. That means you will give to the baby glucose, maybe some minerals, some electrolytes, and the state quite quickly will recover. Since when you give glucose, that means energy to the body, you will, or your body will forget of the defect since it has new energy. And you return the body to the anabolic state. And therefore, the recommendation is not only to give the glucose in acute crisis, but also prevent the states in the metabolism that will lead to the crisis. So if the baby has some problem why she cannot eat, you must think about it, and maybe you should go to the hospital sooner than the actual new metabolic crisis will occur. If you shift into the adulthood, typically these diseases diminish, since your body will be much more resistant to this alteration on the metabolism. So what you must cope with, that's especially the beginning of the life, and then if you are adult, typically the people do not have so severe problem with it. In the newborn screening, you screen for 6 disorders of beta oxidation. 3 of them, you do not have to learn it, but only for your information. 3 are in the carnitine shuttle. As you see here, all the enzymes and translocases in the carnitine shuttle. And then here you have 3 most common defective enzymes of the beta oxidation itself. And why we took for today the deficiency of acyl dehydrogenase for medium chain fatty acids, it's due to the fact that it's the most common defect. As the incidence is around 1 to 6 or 1 to 10,000. That depends what country, what population, but it's the most common of it. And if you take all problems with beta oxidations, they are really quite common. So each doctor should know about it. And other reason why this disease is that if you will look at the genetic, typically the change here is quite simple. Since majority of patients have only 1 mutation when lysine is replaced by glutamic acid. So very simple by the molecular genetic tools to find this disease. And if you found it during the screening, then never the metabolic crisis will occur to the baby, since you will prevent the long-term starvation, and they will have no severe consequences for the life. Any question?
Can you please repeat the lysine replace the glutamic acid?
You do not have to know it, but this is the typical disease. You know, you can have, for some diseases, many mutations that will lead to the same result. Here, majority of patients have only 1 single mutation, and therefore you will read about it, since it's the ideal condition or ideal disease, how to show you how 1 small change in amino acid can lead to severe disturbances. The same is sickle cell anemia. Also 1 substitution in amino acid and absolutely different protein shape at the very end.
Thank you.
Any question?
Can you explain the last sentence?
Why do you measure this? That you should know. If you have deficiency of medium chain fatty acids, then you cannot burn C6 till C10, and therefore they accumulate. That means that you will metabolize palmitate to some extent, and then here you finish, since this dehydrogenase is defective. If you have the short chain dehydrogenase defective, it will be this smaller. If you have the long chain, it will be this.
You said C6?
C10. They have some overlap, you know. That's octanoyl, that's C8. That's C6, C8, C10. The last, that's the xenobiotic drug. So for the xenobiotic metabolism, as the extreme condition, we decided to show you the metabolism of ethanol. So the ethanol is the xenobiotic. That means the compound that is not metabolized or not produced in our body, by our body. To some extent, it can be produced by our bacteria in intestine, but that's only a small amount. So if you give to your body ethanol, what will or how it will modify your metabolism? As you see here, the metabolism of ethanol is quite simple, since the only thing what you modify is this hydroxy group. At the first stage, you convert hydroxy group to aldehyde group. The name of the enzyme is alcohol dehydrogenase. This is alcohol. In the second step, you do the second oxidation. You take ethanol and you convert it to the acid. That means aldehyde group oxidized to carboxylic acid to acetate. The enzyme is called aldehyde dehydrogenase. And then, since here you have acetate, the easiest thing what you can do is to bind coenzyme A to it, and you will form the acetyl-CoA. The enzyme is called acetate or acetyl-CoA ligase. That means the thing that forms the acetyl-CoA, and you of course have to pay for it by ATP. This is the dominant pathway if you have quite small amounts of ethanol in your diet. Here you have possibility to have alternative pathway that's metabolized by enzymes of cytochromes P450. And this is the pathway that is inducible, and you induce it when you have high consumption of ethanol. If we return to the lecture yesterday, I told to you that xenobiotics induce the monooxygenase system. And this is one example of it. This is the monooxygenase system, one representative of it. And if you drink a lot, or your patients drink a lot, you will induce these enzymes. What consequences will have the excess of ethanol to your body? Key first thing is that here you have a lot of NADH produced. So that's the first thing. What do you know is that typically the NADH should be reoxidized in respiratory chain. That's the thing what you will do. But if there is high consumption of ethanol, you will accumulate NADH since the respiratory chain is full of the reduced cofactors. That means ethanol will feed you with a lot of energy, but if there is a lot of ethanol, you can say that it will, to some extent, block your metabolism. And what it will block, that are the pathways that utilize the NAD also. That means that ethanol metabolism will fight together with the Krebs cycle and with the beta oxidation. That means with the pathways that need to have also the NAD to oxidize the substrates. And if you have excess of ethanol, you simply consume the oxidized form and you have a lot of reduced forms. Second thing, what happens in your metabolism is that you shift the balances of some reactions. So typically you shift the balance of pyruvate to lactate, since in lactate you can store the NADH, that means the electrons. And the same you will do with oxalacetate to malate. And this will inhibit the gluconeogenesis. That means for gluconeogenesis you need to have pyruvate and oxalacetate, but if you keep them in the reduced form, you cannot simply run the gluconeogenesis. And therefore, as the result of the high consumption of ethanol could result in the hypoglycemia also. Since if you do not accompany it with some real food, you will block the gluconeogenesis, and after some time you will run out the liver glycogen. And also you will accumulate the acids, so you can measure in these patients acidosis. That means low pH. Why people after alcohol intake could have a nice nausea and vomiting? The molecule that is blamed for it is acetaldehyde. That means this molecule that is quite reactive, quite toxic for your body, and is blamed of the nausea and vomiting itself. What else happened to your body, as you know, is typically the problems with the liver. In the liver, you have quite strange thing that the liver cells are the main body organ to metabolize ethanol, and therefore they have really high amount of energy. Plus, they have high amount of acetyl-CoA. And if they have this, they can produce the fat. They will start to produce the fat, and since it's the overwhelming amount of the fat, it will accumulate in the hepatocytes. And they cannot all the fat transfer into the peripheral tissues. And this accumulation of fat in the liver will lead to the condition that we call fatty liver disease. And if you look into your books or at web and you put alcoholic fatty liver disease, you will find that it's one of the first things what you can find on the liver if you have the patient that is drinking a lot. That means that the people will start to store more fat in the liver. That's normal. This process is typically reversible. If they stop drinking, they will release the fat from the liver and they can regenerate. But if you have the chronic alcoholic person, then the combination of the storage of the fat, combination with the reactive oxygen species produced in the liver, will lead to the inflammation, to the fibrosis in the liver, and as the result, you can develop the liver cirrhosis. So as you see, a lot of energy is not only a good thing, but for example, at the example of ethanol, it can be harmful for your body since too much of fat plus energy plus reactive oxygen species in one tissue can lead to the irreversible damage to the tissue. Any question to ethanol?
Concerning the irreversible damage to the tissue, liver can regenerate.
They can. Liver can regenerate quite nicely.
Yeah, but you said is it possible
to some extent, you know, liver have extreme regeneration capacity. But if you give to them harmful stimuli for a long time, they exhaust their regeneration capacity. And in that moment, you have the liver failure. Any other question?
Yeah, that's